Okay, we will have Dr. Krishnan Ravindran. He is PY4 here at our neurosurgery department. He did his medical school at Jones International School, and then he did in 2011, 2014, his bachelor in physiology biochemistry in the University of Toronto. Then he did his MD from 2015 to 2018 at University of Melbourne in Australia. Then his postdoctoral research fellow in Mayo Clinic, Rochester. After that, he continued doing his training, his internship at University of Florida, doing his general surgery internship. And then he came with us for neurosurgery residency at Mayo Clinic, Florida, since 2020. He has received many honors and awards. Can you go to the other one, Dr.? And now we can see his impact on the literature. He has an H index of 15 and many citations. And now we can see his more of his impact in the literature in many other platforms as Scopus. And he will be presenting middle meningeal artery embolization for chronic subdural hematoma.
I just want to mention, Sanjit and Krishnan, that Krishnan's impact on the literature is already higher than many of our assistant professors around the United States, and many of our services. So congratulations, Krishnan, and we're looking forward. It's a great honor to have you here with us and to have you present. I don't know if Kai, are you there on the line of residency director? You want to say a few words? Maybe Kai didn't join us this morning, Sanjit, but since you're the new assistant, maybe we have actually Selby here on the line. Selby, you want to say a few words?
Yeah, sure.
Sorry.
So, go ahead, Kai. You're on.
No, go ahead, Selby. Sorry, I was rounding.
Just want to introduce Krishnan. He's been a great addition to our residency program since he joined us a few years ago, and everyone really enjoys working with him. He's been a great asset, and he's now doing his trauma rotation over at UF Health here in Jacksonville, which I'm sure he previously did his internship there. I'm sure he's happy to go back to familiar surroundings, though after a month he'll be missing the comfortable walls of a Mayo Clinic, I'm sure. But welcome, Krishnan, and look forward to your talk on middle meningeal artery embolization.
Thank you for the kind introduction from everybody. I'm going to go ahead and share my slides. All right, can everybody see those slides? Thank you. Yeah, like Dr. Chen said, I've been just started my trauma rotation here at UF. We had a relatively busy weekend. We had a C6-7 fracture dislocation come in an 80-year-old lady with an MBC. So we're going to take her for posterior backup today. Parasagittal meningioma come in, and actually another MET come in this weekend. So I've got some good cases planned for today and tomorrow. I wanted to talk about a little bit of an overview on the recent developments in the technique of middle meningeal artery embolization for chronic subdural hematomas. It's a topic that's garnered quite a bit of attention in recent years, and there's essentially been an explosion of papers and groups around the country reporting their experiences, and I wanted to include a little bit of our own experience. As Dr. Graywall had mentioned at the beginning of this, we've been doing this, using this technique for just over 3.5 years, and done about 50 cases, which I'll go into detail a little bit more in this talk. It's a little bit of an overview of the talk. I wanted to discuss as well some of the underlying mechanisms behind the role of membrane formation in chronic subdurals, as well as give a broad canvas on the overall prevalence of the disease. And importantly, I wanted to emphasize some of the important anatomical tenets to be cognizant of when performing these procedures. Chronic subdurals, as everyone knows, are kind of the bane of the neurosurgical disease burden. They are an underrated disease entity in terms of both incidence and prevalence, and perhaps underemphasize their overall contribution to morbidity and mortality. There's been a couple of recent papers that have essentially looked at the global incidence, one of them looking at the global incidence in a systematic review, and another one following a series of cohorts in Japan and through a combined multinational study looking at almost 65,000 cases. And what we know from this is that the incidence is high. It's almost 15 to 20 per 100,000 person years. And in patients considered above the age of 65, that incidence rate can approach almost 60. The rates of functional outcomes that do not allow for independence in activities of daily living are nearly 30% in these patients. And notably, as everyone is familiar with, these lesions have a very high propensity for recurrence, which is one of the roles that MMA embolization as a technique has tried to address. The underlying pathophysiology of the chronic subdural is outlined here. Essentially, there is an index insult, be it either traumatic or through some other mechanism, that results in avulsion or some sort of injury to a cortical bridging vein and leads to the formation of an acute subdural. Over a period of days to weeks, a clot organizes through the canonical pathways of thrombus formation and organization with fibroblast recruitment, and an inflammatory response is generated. Ultimately, what occurs in the proportion of chronic subdurals is the formation of this neomembrane. And the underlying mechanism, this is this perpetuated cycle of microbleeding, inhibition of clot absorption, and subsequent degradation of the clot due to the friability of the newly formed clot, and then repersistence of microbleeding. Excuse me. What ends up happening is the development of a hyperfibrin layer across this neomembrane. This is a cartoon from the previous paper just to outline some of the molecular mechanisms that underlie this pathophysiological process. Some of the implicated molecules that have been identified are vascular endothelial growth factor, as you can see here, and importantly, the Thai angiopoietin-2 cascade. Several papers have demonstrated using both ELISA to analyze protein, as well as qPCR to analyze mRNA, that the levels of VEGF and angiopoietin-2 are elevated in the hematoma fluid from chronic subdurals. So essentially, you have this pro-angiogenetic milieu, and you get activation of several of these downstream cascades. Some of the other important molecules that have been implicated include the fibroblast growth factor cascade, as well as hypoxia-inducible factor 1 alpha. You can see here on the right some of the implicated cell lineages as well. The underlying mechanism through which this technique has arisen is the vascular supply to the neomembrane. And this has been postulated and believed to occur primarily through the middle meningeal artery. And so the idea is that interruption of the middle meningeal artery could reduce this cascade of microbleeding and also reduce the supply of these inflammatory cytokines that you see here on the previous slide, specifically IL-6, IL-8, and TNF-alpha. The evidence for this has kind of been accrued through 20 years of work, and several studies have demonstrated how radiographically enlargement of the MMA is seen in patients with chronic subdurals and prominent membranes on CT and even MR, which suggests that the majority of this blood supply arises from this vessel. Just wanted to touch base a little bit on the anatomy of the middle meningeal arteries. As everyone knows, most commonly arises from the internal maxillary artery off the external. And its course can be separated into an extracranial and an intracranial course. The extracranial course is relatively constant, going between the lateral pterygoid and the spheno. mandibular ligament, and which point it enters the skull base at the foramen spinosum. Upon entering the skull base, the middle meningeal artery grooves the greater wing of sphenoid and then divides most commonly into an anterior posterior branch, but can also divide into, have a trifurcation into an anterior, middle, and posterior branch, approximately near the pterion. There's two important arteries to be aware of that arise pre-bifurcation of the middle meningeal. One of them has a fair amount of attention that is given to it just because of the important structures that it supplies, and that's the petrosal artery. The petrosal artery typically rises anteromedial, and importantly, it supplies segments of the facial nerve, the labyrinthine segment of the facial nerve, the greater superficial petrosal nerve, and it can also supply elements of the Gasserian ganglion. And so the implication for this is that when conducting these procedures, if the microcatheter is placed too proximal, then there's a risk of embolizing the petrosal artery or its branches, and therefore risking a facial palsy or even a palsy of the petrosal nerve. The other important vessel that perhaps doesn't get as much attention in the literature is the cavernous artery. And the cavernous artery is less commonly seen, and it's a much smaller vessel, and it represents an important extracranial intracranial anastomosis. It typically can anastomose with the inferolateral trunk coming off the cavernous SCA, but importantly, it can also head medially to supply elements of the trigeminal ganglion and Meckel's cave, and it can also supply elements of the cavernous sinus. On these angiograms, you can visualize the petrosal branch of the middle meningeal artery arising pre-bifurcation. This is a figure from a very good paper outlining some of the important anastomoses and variants of the MMA by Jaime Martinez, who was one of Dr. Q's prior fellows. Perhaps the most important anastomosis of the middle meningeal artery to be clinically concerned for is the presence of orbital anastomosis. And what I'll present here is that though probably 2 to 3 main anastomoses are described, these anastomoses are arguably a spectrum of anatomic variation. And so it's important to be aware of this spectrum when undertaking these procedures. The sphenoidal branch of the middle meningeal artery heads medially to the orbit. You can't really appreciate it here on this angiogram, but you can kind of make out wisps of it on the AP. And essentially, there are, broadly speaking, 3 variations to be aware of. One is what's called the meningo-ophthalmic artery, and this is where the MMA completely supplies the orbit. And so this is an absolute contraindication for proceeding with an MMA embo for chronic subdural. The other commonly encountered variant, more common than the meningo-ophthalmic variant, is the presence of a meningo-lacrimal artery that you see illustrated here. And basically, this is an artery that can course typically from the anterior branch of the MMA, so post-bifurcation, and it can either enter the superior orbital fissure through the other structures that enter the SOF, or it can enter through its own foramen, which is called the foramen of Hurdle. And from there, it gives off the lacrimal artery that ends up anastomosing with branches of the ophthalmic artery that you see here on this angiogram. This figure is from a paper by Dr. Maxime Shapiro. So for those of you who don't know Dr. Shapiro, he's the creator of the website Neurangio, which is this incredible resource for angiographic anatomy, essentially like Radiopedia, except for neurointervention. And this is one of his papers, his recent papers in the Journal of Neurointerventional Surgery, and describes the continuum of middle meningeal variations that can be seen. So on the far right, you can see the 2 variants that I just had touched base on, the meningo-lacrimal variant and the meningo-ophthalmic variant. Here you see the typical adult pattern. So you can see the middle meningeal just behind, and then its bifurcation, and you can see the posterior and anterior branch, and you can also appreciate a sphenoidal branch. You don't see the petrosal or cavernous segments here. The other important variation is a recurrent meningeal branch, and in this case, the supply is the opposite. In this case, the ophthalmic is coming back and providing supply. So this represents another absolute contraindication, essentially, if you were to embolize proximally. What can be attempted is to traverse the microcatheter much more distal to super select one of the distal branches, either anterior or posterior. But if they're diminutive, this might not be able to be done. And of course, the implications for this are, depending on the type of embolization used, there can be a very high risk of blindness, either complete or partial, from embolic material traversing down to the orbit and through the ophthalmic vascular channels. This is just to give a historical perspective. You know, people talk about MMA embo as if it's only a recent technique, but in fact, the very first paper outlining use of middle meningeal artery embolization for chronic subdural was published in 2000. It was a case report from Japan, and the authors treated a 59-year-old gentleman that had this large right-sided chronic subdural and had 2 subsequent surgical procedures, both by burr holes and then 1 bedside irrigation procedure, and it failed. So it had 3 reaccumulations, and decided to take him to the angio suite and inject polyvinyl alcohol particles into his MMA 2.5 months after he presented symptomatically. And as you can see here, this is a progression of his subdural. So this is what his scan looked on initial presentation. So nearly 2 centimeters of thickness, fair amount of midline shift. So he was taken to the operating room for evacuation. The middle CT represents his CT after the 2nd reaccumulation, so in between the 3rd and 4th surgeries. The final CT on the right is 7 months post-op, so 7 months follow-up after his MMA was shut down. And you can see in the interim between how the thickness has already decreased and his midline shift was much improved compared to his prior CT in between the surgical evacuations. And so one of the important questions that arises is who benefits and what is the ideal patient that may be selected for this procedure. Historically, based on literature in the last 4 years, there's been essentially 3 groups of patients that have been selected for MMA embolization. And these groups were specifically outlined in one of the largest studies, one of the earliest largest studies by Dr. Link from Cornell in this neurosurgery paper from 2019, where they published a series of 60 cases, 45 patients. So the 3 groups are: 1, patients who are offered upfront MMA embolization. So these are patients that are not offered surgery. They have essentially minimal symptoms or are neurologically intact. They have minimal midline shift. Their thickness may be larger. They may have subdural thicknesses of 1.5, maybe even 2 centimeters, but either owing to cerebral atrophy or the presence of other factors, they are asymptomatic or have minimal neurological deficits. And so these patients may be candidates for upfront MMA embolization without any offering of surgical evacuation. The second group of patients represents patients who have already undergone surgical evacuation and are either offered MMA embolization prophylactically in the postoperative period to shut down the vessel and limit the formation of any vascularization to the neomembranes, or patients who have been taken to the OR either for burr holes or craniotomy have recurred and have subsequently been deemed candidates for an MMA embolization procedure to treat the actual recurrence. So patients who have recurred through the chronic subdural. And again, the whole concept here is the presence of both minimal mass effects and minimal neurological compromise. And so as you can see here on this case report, for pretty much everyone can essentially agree that the scan on the far left in a symptomatic patient with substantial midline shift and a thick subdural is an operative case. It's hard to rationalize taking this patient for an upfront MMA embolization when they come in with a contralateral hemiparesis and this much midline shift. But if this patient had presented with the second scan where you see minimal midline shift, but you still see the presence of probably an 8 to 10 millimeter subdural, chronic subdural, then they may fall into one of these categories where we may have offered upfront MMA embolization had they not had the prior history of evacuation. The other important thing to consider is patient comorbidities and the use of antiplatelet and anticoagulant therapy. So in this prior case report, this patient was a cirrhotic patient with coagulopathy. One of the largest series to date is a multi-center series spearheaded by Dr. Khan at Baylor, and they had almost 15 institutions collectively pooled in their data set, and they looked at almost 140 patients, 155 procedures. Their inclusion criteria were not very discrete, however. They included patients with symptomatic chronic subdurals and minimal midline shift, but they didn't specify an actual value for midline shift. And essentially, the decision to treat via upfront MMA embolization was at the surgeon's discretion. If you look at their data set, though, their median subdural thickness was 14 millimeters, and there was minimal midline shift. So 25% of the patients had essentially no midline shift, and the median was 3 millimeters in their cohort. Some exclusion criteria that may be considered: so acute subdurals, obviously operative acute subdurals in patients with neurological deficits or presenting obtunded, comatose, are obvious. It seems obvious to say, but these are obvious inclusion criteria. The presence of significant midline shift. The idea is that, as we've mentioned before, the way middle meningeal artery embolization works is by reducing the blood supply over time. So by definition, it cannot reduce acute mass effects, and therefore is probably poorly suited for patients presenting with substantial midline shift. The other important thing to consider is that, as you can see, based on the blood supply, the best candidates for this procedure may be patients with pan-hemispheric subdurals or large convexity chronic subdurals. Patients with focal isolated lobar subdurals may not necessarily benefit, because this would require selecting either their anterior, posterior, or middle branches selectively, which may or may not be feasible depending on the caliber of the artery. And of course, any underlying conditions causing subdurals, so patients who are overdrained for whatever reason, or patients with intracranial hypertension or another mass lesion. These are some of the embolization techniques and some of the important things to consider for the interventional practitioner. So in terms of embolic material, particles have historically been used for the last, I would say, 5 or 6 years based on the literature, but up until probably 2020, they were the most commonly used embolic agent. Recent studies have started to look at onyx and other liquid embolic agents, and few other practitioners and few other groups around the country are also using coils as a method for embolizing as well. The other important things to consider from the interventional standpoint are site of access, transradial or transfemoral approach, and the anesthesia technique used, so conscious sedation versus general anesthesia. Of course, this is a dural-based vessel, so keeping patients awake may be logistically difficult. So at least at our institution, the majority of procedures are performed under general anesthesia. And in recent years, we've tried to use the radial first for a lot of these procedures where possible, given a patient's radial artery anatomy. The other important thing to consider is whether one will decide to shut down both the branches or just one branch. That is the dominating branch, which I'll show in some illustrative cases, that supplies a majority of the subdural. In terms of the discussion point regarding particle agents versus liquid agents, so this is kind of a topic that applies to any essential embolization, not specifically MMA embolization for chronic subdurals, of course, whether it be for a tumor or what have you. Onyx is more expensive. It does require a DMSO compatible catheter. However, onyx may allow for more permanent embolization of the vessel, whereas particles may result in delayed recanalization. Onyx also, and other liquid embolic agents may also allow for a deeper penetration, which has both pros in that it can shut down the vessel superiorly, but also may have cons if you're concerned for dangerous orbital anastomosis or concerned about reflux back. And a lot of this is just institution dependent. So I scrubbed 2 MMA embolization procedures here at UF so far with Dr. Gregor Brzezicki, who's the neurosurgeon here, and we've used onyx both times. In pretty much every case I've scrubbed at Mayo, the choice of agent has been embazine, so particles. And so this is kind of an overview of our approach at Mayo Clinic. So this is a transradial approach under general anesthesia, but there's various permeations that can be used upon this. So we typically use the benchmark catheter, which tracks well, and place a 6 French sheath, and use the SIM Select diagnostic catheter. The first thing to do is obviously select the ECA, get ECA runs, and then what I didn't have here is also get intracranial head runs, just to, of course, check for any anastomosis. From there, we use an SL10 for our microcatheter typically, and then we perform super selective microcatheter runs to generate good visualization of any branches, any petrosal branches or any orbital anastomosis. And from there, like I said, for the most part, the majority of cases have used 250 micron embazine particles for embolization. I note recently, however, that Dr. Wen and Dr. Wad did use Onyx for one of their cases going through the cerebrovascular database. And so the main advantage to using MMI embolization is reducing recurrence. This is a recent meta-analysis coming out of University of Virginia, looking at the experience with MMI embolization versus conventional management over the last few years. This was published at the end of 2021. And they looked at, they comprised 18 studies, of which 700, just over 700 had patients undergoing MMA embo, and just under 700 had patients with conventional management. So this was either Burho or craniotomy for evacuation. And as you can see here, the recurrence rate was significantly lower following MMA embolization. The surgical rescue, importantly, so that is patients who, despite MMA embolization, still required a subsequent procedure, was still lower after MMA embolization versus conventional therapy. The important thing to note here with these figures is that there's an important selection bias that is perhaps underappreciated. And I'll go into that a little bit more, but basically, if you look at the Venn diagram of patients that were selected for upfront MMA embolization, the majority of these cases were upfront MMA embolization. These patients would not fit in the same circle as the patients obviously offered surgery and then post-surgery MMA embolization, because those patients were typically sicker, had worsening neurological deficit, or had worse radiographic features of the chronic subdurals. So some of these, the direct comparison between these two techniques may be a little artificial, but the recurrence rates as absolutes are important to consider. And so a 5% recurrence rate is still overall lower than has been previously reported for small volume, minimal midline shifts, chronic subdurals treated with surgical therapy. This is their FAR spot from their data set, and it just shows the effect size for recurrence. Recently, there's been several ongoing clinical trials looking at this, and the two predominant clinical outcomes are these two specifically. So recurrence following MMA embolization and the requirement for surgical retreatment. So as you can see here, the FAR spot above suggests that MMA embolization may be favorable for promoting recurrence. This is some of the outcome data from Dr. Link's paper outlining 150 patients. And what you can see here is that the need for retreatment following MMA embolization is also similarly low at 6.5% in their cohort of 140 patients with minimal mortality. As you can see here, only 6% of patients had an increase in their subdural that was symptomatic. And this is the other thing I wanted to touch base regarding the selection bias of using upfront MMA embolization and some of the outcomes reported. So if you look at, this is a data set from another multi-institutional paper using some of the overlapping patients that were described in the previous paper. Essentially, the patients that are selected for upfront MMA embolizations are clinically markedly stable and with radiographically smaller subdurals in both thickness and midline shift. And so saying that they have substantial improvement or looking at the percentage improvement or percentage clinical improvement might not be the best way to assess how well they do with these procedures. The other important thing to consider is how much the subdural itself actually decreases in sizes. And this, I think, is an objective easily measurable data point that can be determined from postoperative follow-up CTs. And I think really this is unquestionable. The data is quite granular here in that once MMA embolization is done, there's a substantial proportion of patients that experience a decrease in size in the max thickness of the subdural. So this is a paper from Barrow looking specifically at that. And as you can see, essentially in 3 months, the mean thickness of subdural has gone from 17 millimeters in their cohort all the way down to 3 millimeters. Importantly, in their cohort of patients on multivariable analysis, the only variable that was associated with 3-month clearance was the ability of the embolic material to penetrate distally. The problem with considering patients, or the notion that must be considered with considering patients for upfront MMA embolization is the risk of progression. And so in these patients, you embolize their MMA in a patient, let's say with a 16 millimeter chronic subdural, and there's a substantial time period, as you can see. It's actually surprisingly shorter than you would expect, but there's still a good, I would say 6 weeks, 2 months, where it takes the subdural to decrease in size, as you can see from these data points. And so there's a risk of progression with the residual subdural that exists following embolization. The other important thing to consider is when surgically evacuating the subdural, you reduce this inflammatory milieu. You get rid of all this pro-inflammatory cytokine that's sitting around in this hematoma. This is another paper that's looked specifically at this phenomenon. Basically, the question they asked was, how long does it take for a hematoma to resolve once you've taken it down by embolizing the middle meningeal artery And they essentially separated the types of subdurals that they saw based on postoperative imaging into several categories, determined based on the density of the subdural. And this was just to follow the phase of loss of blood supply and devascularization of the neomembranes. And the important thing to consider is that initially you get formation of septations, just as you would expect in the typical chronic subdural that remains untreated, but this is accelerated by the presence of MMA embolization. And what eventually happens is that the density of the subdural decreases and it starts to reabsorb as its blood supply is lost. As you can see here, based on the different phases of the subdural, the thickness starts to decrease and the midline shift eventually starts to improve. And the ideal scenario is to get a subdural that essentially has looked something like this, all the way down to being completely hypodense and therefore to promote reabsorption after you embolize the MMA. I wanted to touch base on 2 illustrative cases from our experience that we've done in the last 2 years. The second one is quite interesting, and I think we'll probably put it in together for publication because it's actually a patient who failed MMA embolization. The first patient is a 70-year-old male who was undergoing workup for fatty liver, and he had an MRI brain ordered by his primary care and was incidentally found to have this large pan-hemispheric subacute on chronic subdural, measured 1.5 centimeters in max thickness and had about 7 millimeters of midline shift. The patient was neurologically intact with no focal abnormality. And despite his fatty liver disease, his coagulation parameters were actually normal and his platelet count was normal. Given the fact that he was neurologically intact and given the size of the subdural, the decision was made to take him to proceed with middle meningeal artery embolization. So this is the intraoperative angiogram that you can see from this patient. And so this is an injection of the right MMA embolization, and you can appreciate the cotton wool staining on the AP here and on the lateral. And this is the small vascular channels through which the middle meningeal artery is supplying the subdural. You can appreciate that in this patient, the majority of the supply is actually from the anterior branch, and there's not much from the posterior branch. And the majority of the subdural is really anterior and frontal, with a little bit of a parietal component as well. So we use 250 micron embazine and we took down his MMA. And as you can see here, this is the final common carotid run. And all you can appreciate is, let me just find my cursor, is a wisp of his MMA leading up to the bifurcation, going up into the foramen spinosum. And after that, it essentially just stops and you don't see any middle meningeal artery at all after embolization. The patient did well after the procedure and he was discharged post-op day 1. This is the patient's scan on the right side at his 2-month follow-up. So this is his index presenting scan and this is his 2-month follow-up scan. And as you can see here, his midline shift has pretty much completely resolved. The subdural has decreased from a thickness of 15 to 4, and the patient remained neurologically intact and was doing very well. He was undergoing workup for his fatty liver disease. The second case is an interesting case. This is a 47-year-old female who had a history of multiple sclerosis with a frequency of flares of approximately 2 to 3 a year. And she had a fall about a month prior. During one of her follow-up MRIs to assess for flare recurrence, she was incidentally noted to have this isodense left subacute subdural. It measured 14 millimeters in maximal thickness and produced about 2 millimeters of midline shift. She was, again, neurologically intact, non-focal on examination. So we offered her left MMA embolization in a couple of days after. The procedure itself was uncomplicated. These are intraoperative angiograms here, and importantly on this study, you can appreciate, so this is the microcatheter here is before the bifurcation, as you can see, and you can appreciate wisps of orbital blush from the sphenoidal branch of the MMA here. Importantly, in this case, in contrast to the prior case, you don't appreciate some of the obvious cotton wool staining of the subdural, and really this is just due to the time course. As you can see, there just hasn't been enough time for neovascularization across the membrane to occur. And this is, of course, expected just given the density of the subdural on CT. At any rate, we used a transradial approach and shut down our MMA using 250 micron embazine particles, as you can see here on the right on the post-embo angiogram. This patient actually represented to the emergency department 3 weeks after we did the MMA embolization with worsening headaches, and so she was rescanned. The far left CT shows her initial scan before we did the MMA embolization. This CT shows her scan on representation to the emergency department. As you can see here, the subdural has enlarged and has formed new septations with suggestion of subacute blood within the septations. She remained neurologically intact with no focal motor deficit and no pronator drift, but given the size and the presence of now new midline shift and septations, we decided to take her to the OR. So she was taken to the OR the next day for a craniotomy for evacuation, which went uneventfully, as you can see here on the post-op day 2 evacuation scan. And she was discharged from home on post-operative day 2. She was seen and follow-up in 6 weeks with this scan that you see on the far right. And as you can see here, the subdural has almost completely resolved. There's just a thin rim of it that you can appreciate there, measuring 2 to 3 millimeters, and her midline shift had completely resolved, and she was doing very well clinically. Before these cases, I just want to touch base on some of our experience to date. And so we've done just under 50 patients for MMA embolization thus far, and this dates back to essentially the end of 2018 or early 2019 until present day. In our cohort, our recurrence rate has essentially been 1 out of those patients, and that was the patient that I just showed, so a recurrence rate of 2.1%. And like I had mentioned before, at least from the technical standpoint, the majority of our cases have been performed using particles, 250 to 350 embazine. And so what are some of the things to look at going forward for expanding the practice and expanding the patients that may be selected? Well, I think some of the variables that need to be considered are who exactly benefits and who is the ideal patient to consider, because the ideal scenario is to get every patient with a postoperative scan that looks like this following MMA embolization, where the subdural has nearly completely resolved or reduced to a very small amount, and the midline shift is substantially improved. And so I think there are still important questions that need to be answered on which patients are ideal to select for this. The other thing that's important to consider is what is the ideal follow-up time for these patients. Based on some of the data that I presented, typically the most commonly used data point is 3 months for determining radiographic clearance. But as you can see here, there may be instances of patients where due to failure of the procedure, earlier follow-up may be warranted. And the other important technical consideration is the type of embolic agent used. Are particles the best? Are liquid glue agents the best? Are coils the best? So far to date, no study has demonstrated superiority of one embolic agent over the other. But like I said, recent years have garnered attention to use of non-particle agents for embolization. These are some of the ongoing trials. There's actually almost 19 ongoing clinical trials investigating MMA embolization. These are some of the largest trials. So Embolize is one of the largest trials ongoing, and it's looking at surgical controls versus patients randomized to surgery plus MMA embolization in the interventional arm. And this trial is using onyx as their embolic material. Membrane is the other clinical trial that's ongoing, and this is using glue as their embolic material, and they essentially have 4 arms. So the 2 control arms are standard of care surgery, either burr holes or craniotomy, and standard of care medical management, and they're randomizing patients to 2 interventional arms of surgery plus embo or medical management plus embolization. The other ongoing trial is from Washington University in St. Louis, and this is using PVA particles. And they're similarly randomizing to an embolization only arm plus an embolization and evacuation arm. But in this case, their control is actually the upfront MMA embolization arm, just to see what the utility is of upfront MMA embolization versus MMA plus surgical therapy. This is basically what I had regarding this topic, and I think in the future we're going to see hopefully a lot more patients that may benefit from this technique. From the interventional standpoint, it doesn't take very long to do, and there's a wide scope, and hopefully more patients will be able to benefit, and we'll see more papers coming out about the long-term radiographic and clinical outcomes. Thank you.
Great job, Krishnan. I think that was a really great review of the literature out there, as well as really looking at the anatomy and looking at some of the anastomosis that can be very important. I know Dr. Nguyen had a case where one of those was present recently. So it's important to know about these when we're doing it. What are your thoughts as to why there was recurrence in that one case you showed us? Or actually not only recurrence, but progression of subdural?
I think in this specific instance, it had to do, let me just go back to that CT. I think in this specific instance, this subdural just simply hadn't matured enough. And when we talked about the pathophysiology of the chronic subdural, that cycle of rebleeding and then a clot formation, the most important step, arguably, that allows vascularization from the MMA to supply the membranes is fibrin deposition. And I think in this patient, that simply hadn't happened enough. So this subdural had been there for just under 4 weeks. So I think looking back, one of the things we could have considered is giving this more time to mature and then shutting down her MMA. The other thing is the reason we didn't consider upfront surgery for this is her age. She was 47 years old, so we wanted to save her potentially invasive surgical procedure, which obviously she ended up having nonetheless. Really, her MS was well controlled, and she didn't have any other comorbidities. She wasn't on any antiplatelet agent, any anticoagulant agent. But looking back, I think if we had allowed this to mature for another 4 weeks, maybe there's a chance that this would have shut down with taking down her MMA.
Has anyone looked, and maybe Chris or one of our neurointerventional guys can comment on this as well, has anyone looked at the wisps, the cotton wool wisps you talked about, and the degree to which those are present in the angio to correlate to see if that, Because I feel like if you look at MMA embolization and you don't really see that flush of the membrane, then maybe if you shut it off, it's really not going to make that big of a difference. I don't know, but it's a question.
No, it's a very, very valid point, and nobody has specifically correlated the presence of continental staining on angiography with success rate of MMA embolization as of yet. Essentially, people have only looked at CTs, but it's a very good point to look at. I think I might actually start doing that. The thing is, you don't know until you get to the angio suite. You have an idea based on the CT, but you really don't know until you get to the angio suite. And then when you see the angiogram, it looks like this, and you don't see, like you said, obvious supply from any of the distal branches, then maybe it's time to consider that this patient may have benefited from an alternative therapy, or this patient may have benefited from waiting and watching this for a little bit longer.
Well, and first of all, Krishnan, an excellent presentation. You've delivered what we've all come to expect from you. It's a wonderful review, and you bring up a lot of great points. And specifically addressing this, yes, I think you're very on track about the second patient. This has always been a technique that's been directed towards chronic subdural hematomas, and not acute lesions. And it may be, just as you have pointed out here, with the pathophysiology of the disease, what we're seeking to do may not be possible until some of this neovascularity matures a bit. And you are right, it is a little bit difficult sometimes to know when. And one of the things is, a lot of the times you don't see that prominent neovascularity until you've started your embolization. Sometimes that kind of blush comes as you plug up some of the more distal vessels. So it is a bit of timing. It is a little bit of difficult in figuring out just when to do this. But I think the idea of looking at the angiograms and seeing if we can stratify some of this via timing of the subdurals as we know them, in the patients we may know the onset, et cetera, would be very helpful. And I think it's a really good question. But that's something certainly we can look at. An excellent presentation.
Sure. And the other important caveat is, just like any technique, it's really patient selection. If you have a hammer, then everything becomes a nail. Not every chronic subdural. The other point I was trying to illustrate is that not every isodense or hypodense subdural is a candidate for MMA embolization. In certain patients, there's might be worth considering another technique.
No, agreed very much. Yeah, the interesting thing about the debate goes on about particulate embolization and liquid embolization. A couple of trials that are going on partly is because of the interest in some of the companies that make the liquid embolic agents. There is a theoretical advantage to distal penetration, and it's been discussed with respect to tumors as well as with respect to this disease. And there is perhaps a theoretical advantage to deep penetration with some of the liquid agents. The problem with that, though, is you don't always get it. And one of the things that happens with a liquid agent, if it decides to follow a pattern where it congeals proximally, and you start to get backup, you may have to abandon your procedure before you can get the deep penetration that you're looking for. With particulate embolization, you can go as small as you want with particles. We tend to go a little larger with particles, but the truth is that with the anatomy that you're working with, you don't really have one of the reasons to go with larger particles is that you don't disrupt the small vessels that innervate nerves and things like that, and you don't really have that distally here. So you could actually go with even smaller particles than the 250s, and not that it necessarily provides an advantage, but certainly the particulate embolization is cheaper, and you almost always get a pretty good distal distribution. So that's one of the reasons we have been using it. But there certainly may be advantages in certain patients to onyx or squid or one of the other liquids. But
yeah,
it's a question.
Actually, Dr. Walid Brzezinski up at Mayo, who's essentially pioneered CSF venous fistula treatment with Dr. Wen, he'd written a commentary on one of these articles on the debate of particles versus glue. And essentially it comes down to surgeon preference over comfort versus the risk of any agent going and reflexing down through an ophthalmic or orbital anastomotic channel versus the possibility that you might not be able to completely shut down the MMA and you might be back in a few weeks or a few months in a patient such as this or in a different patient. At least for the other thing to consider is that you can see the cast of onyx when you visualize, when you do a blank roadmap. And
True.
really, you can't see that with the particle embolizate. And so that's the other thing to consider.
True, that you can see your your embolizate has contrast. So each time you inject, you can sort of see how it refluxes. So you can control them both. But agree, there are, as I said, my basic concern in my experience with Onyx has been that is sometimes you get a proximal plug and it just keeps walking proximally, and sometimes you don't have that much room to let it, because then what you usually do is you let it sit, let it harden, and then try it again, and hopefully it will move forward instead of backwards. But if it moves backwards too many times and you get too close to, say, your foramen spinosum, then you sort of have to abandon your procedure without having gotten the result that you want.
That's
Whereas
true.
particles, if you're careful and control things, you can sort of shut things down. The other point is with your anastomotic channels, you made a very good point about that. And one of the things that people forget is sometimes you need to do an interim angiogram, because that for these in this situation and in other situations, because sometimes these anastomotic channels aren't noticeable when you start your embolization, but as you shut down more distal things, then sometimes those anastomotic channels open up partway through. So you have to be a little careful how you do that and make sure that you're checking throughout the procedure. But again, really excellent review of this.
Thank you. Well, the other thing I wanted to say just on the branches is that in the cases I described, the caliber of the vessel was quite large. So this is the first case, and this anterior branch is quite prominent. So you could easily, decide that you wanted to super selectively catheterize something more distal here, and then start blasting, and then you can pull back your catheter to not risk gluing it in place, and then come out.
True, and I do that actually usually with my MMA. I'll put in a little verapamil to open up those distal vessels to make them a little bigger, and then advance my catheters. And I usually like to do just that. I like to go anterior, pretty as far anterior as I can, and blast. That way, I have a lot of good, and then I can just walk back a little bit, and then I can go out selectively out the posterior and do it that way, and it's good.
Krishnan, thanks for that talk. I just wanted to make one other comment. I think that that patient you showed that failed, it's a little complex to try and understand why they didn't have a good outcome. I think partly it's because we didn't fully understand the pathophysiology of this disease completely. And as you mentioned in the beginning, there's an inflammatory component to this, and shutting down the blood vessels may not be enough to solve this problem. And just for your kind of own edification, in that embolized trial, we were recruiting for that at University of Utah, and they were very restrictive in terms of medicines that the patients can also be on. So specifically, you weren't allowed to use steroids, which was very common. And a lot of people today, when they do MMA with particles, will commonly put the patients on steroids, but also things like anti-lipid agents. There's some data to suggest that maybe that may be helpful. So, and I think this debate on, particles versus onyx and is not going to be solved until somebody wants to do a more robust experiment and get some histological samples of these membranes. So it'd have to be a group of patients that got embolized, still went to the OR, and then you can prove, whether or not these particles are actually penetrating these membranes. And I think that'll help kind of clarify things.
Yep, it's a very good point. Thank you.
Well, thanks, Krishnan. I think we're running out of time here. So I just want to say excellent job with the talk. Enjoy the rest of your time over at UF Health, and we look forward to seeing you back here at Mayo sometime soon.
Thanks, Dr. Chen.
All right. Thanks, everybody. Bye.